So our group is doing the depressive disorders. So first up, we have the definition and features and an overview of the depressive disorders. We have major depressive disorder, which is characterized by 2 weeks of depressed mood or loss of interest of pleasure for most of the day, every day. Also must experience 4 of the following symptoms: appetite, weight, sleep, psychomotor activity, decreased energy, feelings of worthlessness or guilt, difficulty thinking, making decisions, and thoughts of death or suicidal ideation, and there's a high mortality rate from suicide. Next, we have persistent depressive disorder, which is characterized by a depressed mood for most of the day, more days than not, for a duration of 2 years. During the depressed moods, 2 of the 6 symptoms must be present, which is appetite related, sleep related, low energy and fatigue, low self esteem, and poor concentration, and feelings of hopelessness. So next we have premenstrual dysphoric disorder. Essential features include mood lability, dysphoria, anxiety that occur during the premenstrual phase and remit around the onset of menses or after, and symptoms peak at the onset of menses. Must be symptom-free in the follicular phase after menstruation begins. Substance and medication-induced depressive disorder is a disturbance in mood that predominates the clinical picture in depressed mood and diminished pleasure in all activities, and this must be due to the physiological effects of a substance, and depressive symptoms must have had to develop during or soon after the substance use and withdrawal from a medication. Next, we have depressive disorder due to a medical condition. So the prominent disturbance in mood that predominates the clinical picture and is due to physiological effects of another medical condition. And this first must establish a mood disturbance that is etiologically related through physiological mechanisms. Next, we have disruptive mood dysregulation disorder. This is characterized by chronic and severe irritability. There's 2 clinical manifestations. The first one is frequent temper outbursts that occur frequently, and the second one is chronic and severe angry mood that's present in between severe temper outbursts and is present for most of the day, nearly every day, and noticeable by others. Then we have unspecified depressive disorder. This is used when symptoms, characteristics of a depressive disorder do not cause clinically significant distress or impairment in social or occupational or other areas of life. Used in situations when the clinician does not need to specify the reason that the criteria are not met for a specific depressive disorder, and also used when there's not enough information to make a more specific diagnosis. Then we have other specified depressive disorder. This is used when symptoms, characteristics of a depressive disorder does not cause clinically significant distress or impairment in social, occupational, or other areas of life, does not meet the criteria for adjustment disorders with depressed mood or adjustment disorders with mixed anxiety and depressed mood. So an example of other specified would be recurrent brief depression. So some of the key DSM diagnostic criteria. So common features of all these disorders, according to the DSM, are a presence of a sad, empty, and irritable mood. Changes must significantly impact ability to function. So examples would be somatic and cognitive changes in major depressive and persistent depressive disorder. And the key difference between disorders is the duration, timing, and presumed etiology. So next we have differential diagnosis considerations between depressive disorders. So bipolar 1 or 2, a potential consequence of misdiagnosing a bipolar disorder of a patient experiencing a depressive episode is that standard antidepressants are shown not to be effective for treatment. We have depression disorder due to another medical condition, so physical illness can also cause depression. Substance-related depressive disorder can cause depressive symptoms. And then we have major depressive disorder, either single episode or recurrent. So this includes for weeks or longer feelings of depression, eating, sleeping, and loss of energy, thoughts of death, no mania or hypomania. Then we have major depressive disorder with melancholic features, which is early morning awakenings and appetite and weight loss, guilt, and failure to feel better even when good events happen. So then next we have major depressive disorder with atypical features, which is increased appetite, weight gain, and excessive sleeping, and major depressive episode with seasonal patterns, so becoming depressed during certain times of the year, like fall or winter, and major depressive episode with peripartum onset, which is developing major depression during pregnancy or 1 month after having a baby, and persistent depressive disorder, so symptoms are typically less severe than major depression, but the duration is years, and there's no psychosis or suicidal ideation. Then we have bereavement, so this is weeks or months of someone who's lost a relative or a friend, and this includes feelings of loss and emptiness, but usually diminish within days or weeks. Then we have prolonged grief disorder, so this is grieving for a year or longer. Adjustment disorder with depressed mood, so responding to life stresses sometimes can cause people to feel depressed. And somatic symptom disorder with mood disorder, so an extensive history of bodily complaints with no physical explanation and can have symptoms of depression and mania.
Okay, and tagging on to what Kristen just explained, a lot of this is the same, but these are the differential diagnosis considerations for MDD. The first one is manic episodes with irritable mood or with mixed features, and these may be difficult to distinguish from manic episodes with irritable mood or with mixed features. Bipolar 1 disorder, bipolar 2 disorder, or other specified bipolar and related disorders, history of correlations between manic or hypermanic episodes, depressive disorder due to another medical condition. Those medical examples are multiple sclerosis, stroke, or hypothyroidism. And then substance medication-induced depressive disorder. It's just related to mood disturbance from the substance. Persistent depressive disorder, depressed mood more days than not for at least 2 years, and both can be diagnosed at the same time. And then premenstrual dysphoric disorder. MDD is not temporarily connected to the menstrual cycle, so that's the difference there. And then destructive mood dysregulation disorder. It doesn't display irritability as MDD does. As for major depressive episodes superimposed on schizophrenia, delusional disorder, schizophreniform disorder, or other specified or unspecified schizophrenia spectrum and other psychotic disorders. Depressive symptoms may be present, but most commonly those are considered associated features. With schizoaffective disorder, they have psychotic features such as delusions or hallucinations for at least 2 weeks, and there's no major depressive episode. ADHD, both have low frustration tolerance and distractibility can occur in both. In kids specifically, disturbance in mood is characterized by the irritability rather than sadness or loss of interest. With adjustment disorder, with depressed mood, a major depressive episode that occurs in response to a physiosocial stressor with a depressed mood. And then bereavement is feelings of emptiness and loss, and MDD has diminished ability to experience pleasure. And then as for sadness, this is just part of human life. And so typical, but MDD, you have to have 5 of the 9 symptoms and show up most days for at least 2 weeks. Jumping into multicultural and neurodiversity. So culture shapes how individuals experience, express, and cope with depression, as well as how they seek help and how society responds to those experiencing it. There are substantial cross-cultural variations in prevalence, the course, and the symptomology of depression. A syndrome similar to MDD can be found across cultural contexts. As therapists, we must explore their meaning in local social context to understand the significance of symptoms. We need to be aware of cultural factors that may influence a patient's experience of depression and tailor the approach accordingly. Um, some cultures emphasize physical symptoms over physiological ones. Some express distress through headaches, backaches, or stomach aches instead of verbalizing they're sad. Research on religion and spirituality in different cultures found for Jewish individuals with MDD, core beliefs about God have been shown to guide coping during distress and impact mental health outcomes. In regards to how symptoms show up, there are a core few that are not in the DSM that show up across cultures, but many that are not. Symptoms that are common everywhere associated with depression are social isolation or loneliness, anger, crying, and pain diffusion. And then continued for multicultural neurodiversity. Stigma plays a significant role in whether individuals seek help and the type of help they seek. This can be underdiagnosed, or this can lead to being underdiagnosed or delayed or inappropriate treatment. Overdiagnosis of schizophrenia, spectrum disorders are common, and those should be watched for. Cultural influences, age, generational development, or other disabilities, ethnicity, racial identity, religion, spirituality, spiritual orientation, SES, and indigenous heritage, national origin, and gender.
Okay, so building off of that, we are just going to talk about some of the recommended diagnostic procedures and assessments that can be used with major depressive disorders. The first step would be starting with the biopsychosocial model to sort of get a deeper understanding of the client's presenting problems, figure out what that sounds like in their own words, um, understand how they express their symptoms, and also be observing for signs. We want to be asking questions about the impact on their work, their school. If their occupation is getting impacted, we can ask about that, as well as how their impairment is disrupting their social functioning and their relationships in their life. If they've had any medical history that would be useful to know, such as medications that they've tried or hospitalizations in the past, as well as some effort maybe that they've tried to treat their current problem. For major depressive disorder specifically, we want to be asking about timelines. If the depressive disorder has been 2 weeks or more, is it daily or at least nearly daily? That would be things that we want to assess for. And something to add to that, as a counselor, we also have a responsibility to be assessing for the risk of harm. So we do want to ask pretty directly about suicidal ideation, which does include if there's any plans, means, or history, as well as the level of intent if we do sense that the client is experiencing suicidality, pretty common with major depressive disorders. A diagnostic procedure or assessment that can be used for that is commonly the CSSRS. One challenge, though, is that you can only answer yes or no to the question, so it can be difficult for counselors to fully interpret the answers there. Um, Naturally, while understanding the context of the client's lifestyle and background, the counselor is truly looking for persistent sadness, emptiness, irritability. Sleep patterns can be disrupted, so we're looking for insomnia or hypersomnia, and then also asking questions about the thought content. If there's any disruption in cognition, maybe their energy is lower, motivation's decreased. And if we want to specifically assess for major depressive disorder, if we're noticing that the client might meet that criteria, we can use the PHQ-9, which screens and monitors clients' symptoms from our perspective based on questions. And then the Beck Depression Inventory number 2 is a self-report measure of symptom severity. So we just want to think about developmental considerations there. Children, adolescents, they might not be as aware or accurate in their self-reporting, whereas adults may be a little bit more just aware of how they're performing. So knowing which one to use when is important. As far as referral and consultation recommendations go, one step we can take is having a client go to lab testing or have a medical evaluation. Sometimes we have underlying medical conditions with our clients, such as a thyroid dysfunction, which can contribute to increased sadness or low energy. We also want to ask our clients how they feel about medication management, and if they're interested, then a referral we can make is to a psychiatrist. Since major depressive disorders can be treated with medications that do also sometimes increase risk of suicidal ideation based on the research, we want to be collaborating with that client's psychiatrist or meds prescriber so that we can track the symptoms and let them know if things have gotten worse or better. We also can consult with school counselors if the client is a youth. Sometimes we want to see how they're functioning in that academic setting from the teacher's perspective, as well as collaborating on supportive interventions to help them be successful in the academic setting. And depending on the severity of needs, if our client appears to have a high acuity risk based on their responses to some of the safety screenings that we do, we might need to refer to some higher level care, including hospitalization, residential, maybe short inpatient or a therapeutic school environment, but just something designed to help in that way. Common comorbidities and the implications of depressive disorders. Often we might see comorbidity with substance abuse related disorders, panic disorders, anxiety disorders, as well as PTSD and obsessive compulsive disorder, and some eating disorders. Notably, women are more likely than men, according to the DSM, to report comorbid anxiety disorders as well as bulimia and somatoform disorders, so some somatic symptoms. Whereas men, again, according to the DSM, are more likely to report comorbid alcohol and substance abuse. As far as mood implications, we definitely notice that major depressive disorders again increase the risk of suicide, especially working with clients who might have deep persistent hopelessness or even a high ideation of suicidality. That is definitely going to be impactful for them. And in work and school, if we notice that the client is suddenly unable to perform at school or they're taking time off of work, these are going to be some ways that the depressive disorders are impacting them in their daily life. I think that covers that part. And these are all of the amazing places that we learned all of these amazing things.